All right, so we're recording. Okay, so I was just talking to some of you ladies about how when you're reading the evaluation and management section, there's a lot of words in there. It can be a bit overwhelming. It can be a bit lengthy. It just is. But I want to point out, and I'm going to pick up my CPT. Instead of moving my camera, I'm just going to pick up the manual. Your guidelines in the green. I'll move back a little bit. Everything that you're reading is in your manual. So when you're going through all those words and you're thinking, well, how am I going to remember this or how am I going to remember that? You don't necessarily have to remember it. It's in your guidelines. If you want to look up, if you can't remember what chief complaint is, it's in your guidelines. If you can't remember what an established patient, you know what I mean? There's going to be pointers there. Today, we're going to be talking about review of systems and all these different things. Well, if you can't remember what one of the systems are, there's a list for you in your guidelines. I'm going to tell you, I know they're lengthy. It's not a party reading them. I get it. But if you'll just assign yourself a little bit at a time and make notes and highlight, then you're going to remember that later. Okay, I have a question. So when you go to evaluation and management, past your guidelines, and it's your first page of codes, do y'all have 99201?
It says it was moved to 99202. It was changed.
Yeah, they took out 99201. So I want to remind everyone that I am working in a 2020 manual and I'm trying to update mine. But I read where they had taken out 99201, which makes sense because when does a new patient only spend a few minutes with a doctor? That's pretty extensive, right? When you're a new patient, they take extra time. Okay. So the thing that I want to point out, or I want to show you now, is I want you to look at 99202. Does 99202 say an expanded problem-focused history? There's 3 little dots. Does it say expanded problem-focused history, expanded problem-focused examination, straightforward medical decision-making? Is that what yours says? What does yours say?
For the evaluation and management of a new patient, which requires a medically appropriate history and or examination and straightforward medical decision making.
Okay, so you do not have 3 little dots like this? 3 little dots.
No, not under that. Not under 99202.
Okay, well let's go to 99211. Let's take a look at that one. I'm sorry, I'm trying to see if y'all how similar they are. No, 99211 is not going to have anything. Look at 99212, and it should have the 3 little dots. Okay, you guys.
Okay, now I got it. I don't know.
Hi, Lariana. Okay, so obviously there's been a lot more changes to the manual than what I have. So
It's giving me problems. It's not, I don't know what it's doing.
you think it might be the weather? Oh, maybe. All right, so I was going to show you something that I've done in the past with the evaluation and management, and until I get a new manual, I don't know what yours looks like yet. So I'm going to go ahead and put that on pause. I am going to do some slides with y'all because what's class without my slides, right? Got to do the slides. The biggest thing that I want you to pay attention to is timing.
Okay, let's try it like this.
So you're going to have different times, 15 minutes, 30 minutes, 45 minutes. A lot of time, that's a big indicator. Yeah, so I'm thrown off a little bit because I was hoping that you guys had those bullet points so that I could point those out. But I'm going to go ahead and just share my screen and we're going to do a slideshow. I'm going to do some review for yesterday. I'm going to do review on key terms because I cannot stress enough that you have to know what a new patient is and what an established patient is. You're going to use those two terms daily. You need to know the difference between inpatient, outpatient, observation. All of those things are very, very important. I think I tried to give y'all a crossword puzzle on it. That would not work. I don't know what happened to that. But anyway, okay, so we're going to start. Share a screen. Oh, hi, Lariana. I'm glad to see you.
Good morning.
So this is our evaluation and management, and this is part 2. We are going to be doing some review, though. Okay, so coding for services. What is your job? It's your job to code what's documented in the medical record. If you have incomplete information, you need to talk to the physician, the physician's assistant, the nurse, but you need to find someone to give you additional details. It's never appropriate for the coder to make assumptions that go beyond the information that's provided. Your job. Optimize, never maximize. Optimize just simply means getting the most out of it. Maximize is to increase or make as great as possible, which means stretching the truth. You don't want to do that. You have to accurately report documented services. Coding for services not provided is a crime. If you didn't document it, it didn't happen. If it's not documented, don't code it. You have to have the medical reports, okay? Just, it's that important. I know that I say it over and you're going to hear it again. If it's not documented, don't code it. If you didn't document it, it didn't happen. That's our catchphrase, okay? So I just needed to look at all of y'all and say, if it's not documented, do not code it. If you need extra information, ask the physician, ask the physician's assistant, or get onto the hospital website yourself and look at the medical records and print those out. Okay, so let's talk about some facts about evaluation and management. I don't know what this is. Let me move it. E&M, which is what we usually say, E&M stands for evaluation and management. It reports physician services. The E&M section is the most frequently used section of the CPT, and that's why it's located first. So now we're going to talk about these key terms that are so very important. So what's a new patient? A new patient has not received any professional service in the last 3 years from the same physician, another physician of the exact same specialty and subspecialty in the same group. New patients are more labor intensive for physician staff. Oh my goodness, my tongue is tied. Okay, I'm coming back to look at you again because I want to talk about new patient. Okay, so coded for a cardiologists, Dr. Landreneau, Dr. Davis, Dr. Chaudhry. Sorry, it took me a minute. Okay, so I went to the cardiologist. I saw Dr. Chaudhry. I made another appointment. Dr. Chaudhry was not available. So I saw Dr. Landreneau. They're all in the same group. So I'm not a new patient. Do you understand that they're like, let's see, Red River ENT, Dr. Wold, there's a ton of doctors in there. They're all part of the same group. Okay. So remember, I went to the cardiologist with these three doctors, but I decided I wanted to go see Dr. Friedman at Friedman Cardiology. Am I going to be a new patient over here? Yes, I will, because he's not part of this group. RRC, Friedman. So when you're assigned a facility to code for, you're going to know who's in that group because they're going to be under the same name. Red River Cardiology is this one. Friedman cardiology is this one. So you're going to know who you're coding for. But they can see a physician in the same group, but they can't see a different group. Do you guys understand that? Thumbs up if you understand. Okay. An established patient has received professional services in the last 3 years from the same physician or another physician of the exact same specialty and subspecialty. Okay, so what is an outpatient? It's a patient who has not been formally admitted to a healthcare facility. For example, a patient receives services at clinic or same-day surgery center. Example, patient is admitted into observation status. Does that sound clear as muddy water? A little bit? Okay, so outpatient and observation, there's a fine line. When you go into an emergency room and you're seen and you leave, it's outpatient, right? But if they keep you past a 24-hour period, because they're doing what? They're observing you. So you're admitted for observation. So how many of you have had day surgery? So you've had your surgery, you were only there for a few hours after, and you left. So that is outpatient, right? Oh. It's outpatient because you didn't stay that 24-hour period. But say you had your surgery, it was supposed to be outpatient, but your blood pressure is all over the place, so they want to observe you overnight. So when you're coding, whether it's outpatient or observation, you'll be looking only at the time. You're going to be looking at the timing of that. Okay? Does that make sense now? Okay.
Ma'am.
So inpatient, one who has been formally admitted to a hospital or a healthcare facility. Your attending physician is going to dictate an admission order, an H&P, and request consultations. An H&P is simply a health and physical, and we'll get into that a little bit more. Okay, so this is where we're going to actually start talking about the things you're going to be reading today. We're going to be talking about contributory factors. I want to remind you guys again that lots of this information is in the guidelines, and you can go back and refer to it at any time. What are contributory factors? They are conditions that help the physician determine the extent of the history, examination, and decision-making required to treat the patient. Contributory factors are conditions, and these are what help determine the extent, the history, exam, and medical decision-making. Do you see the MDM on the bottom, on the end of that? MDM stands for medical decision-making. That's important for you to know. There are 4 contributory factors. There's counseling, coordination of care, the nature of presenting complaint, and time. Some or all of these or none of these may be relevant in any given patient encounter. Okay, so let's talk about the history. History consists of subjective information provided by the patient. Subjective information, you need to make a note of that. Subjective information is what's provided by the patient. The information can include a description of the chief complaint, which is in the patient's own words. What's wrong? What's the chief complaint? Why are you here? A chronological history of the present illness, a review of anatomical systems, and an accounting of past family or social history. A chief complaint's going to be recorded on every encounter because it tells the doctor, why are you here? Now, it may just be a follow-up, so they'll put a follow-up, but usually when you go to the doctor, there's something wrong, right? The extent of a history is going to be determined by the extent to which each of these types of information is required and recorded in the medical record. Okay, so I want to talk to you a little bit about the extent of a history. Okay, I'm going to use Antoinette, for example. She may have had no medical history whatsoever. Say that when she was 5 years old, she broke her toe. That's it, right? Well, for me, I've had a hysterectomy, I've had a gastric sleeve, I've had a biopsy, I've had thyroid removal. So you see the extent of my history is different than the extent of her history. So when she goes to see a doctor, it's different because her history is so minor compared to my history. And I don't know that. I'm just using it, just using your name, Antoinette. But I wanted to kind of you know, and then maybe we can go one step further and say my father-in-law's had open heart surgery. He's got a pacemaker. He's had brain surgery. He has tremors and has had to have a mechanical mechanism put in his brain to help with tremor. So you understand, like, everybody has such different histories. And so the doctor, they're taking that into account every time you go, what your history is. And so medical decision-making is usually largely based on what your history is. All of that information is like a piece of the puzzle. Okay, there are 4 elements of a history. Chief complaint, which you're going to see as CC most of the time, history of present illness, your HPI, review of systems, ROS, past, family, and our social history, PFSH. So I'm going to turn this into a key term because I'm going to tell you what each of these things are. So a chief complaint. Chief complaint is subjective. Why? Because it comes from the patient. Chief complaint is the primary reason for the patient encounter. This will be a brief statement, typically in the patient's own words, of the current complaint describing the symptom, problem, condition, diagnosis, physician recommended return, or other factors that is the reason for the encounter. So chief complaint is, why are they here? And I thought it was really funny because it says brief, and sometimes they're not brief, but you know, there should be brief. So history of present illness, HPI, again, it's subjective. With any illness or condition, there is usually a progression from the point when the symptoms first developed and were noted to the time when the patient appeared for the encounter. This information is captured in the history of present illness. I keep saying pregnant illness. I'm sorry, it's present illness. Okay. How many times do you go to the doctor and does he say, how long has this been going on, Mrs. Gallagher? When did you first notice this symptom? Do you guys recognize those words? That's all part of the HPI. We wouldn't know it as that. We think he's just asking us questions, right? But there's a rhyme and a reason to everything they do. So that's subjective. You're telling him in your own words when the condition started or when the symptoms started and how long. They're going to ask you to say, how bad is the pain? Do you remember the little sad face scale, you know, 0 to 10? You can be picking from that because they want to know, how long has the pain been this bad? Did you take anything that helped your pain? Do you recognize those questions? That's where they're plugging that information in the HPI. Okay. Okay, now we're going to talk about the review of systems. So that's exactly what it sounds like. It's subjective also. It's where the HPI is focused on a current complaint as viewed by the patient. The review of systems takes a broader look at the whole patient. The review of systems is a thorough inventory of body systems obtained through a series of questions designed to identify signs and symptoms the patient may be experiencing. So, why is a review of systems important? Because you stop and you think about, heart patients. You could be having pain in your left arm. Your systems all work together. If you're having a stomach ache, well, it could be gastro, but it could be, there's so many different things it could be. So they're asking you those questions, or they're wanting to take a broader look. If you're coming in for a common cold, they're not going to be doing a review of your systems, right? Got a cold. So it depends on what your chief complaint is, on how far they're going. But if you're extremely ill, they're going to be looking at what system may be affecting another system. So that's what the review of systems are. So here's some examples of systems. Your eyes, organ system. Ears, nose, mouth, throat is an organ system. Cardiovascular organ system. Psychiatric is an organ system. Endocrine, lymphatic, allergic, immunologic is an organ system. And so these are just some examples of organ systems. Again, this is in your guidelines. It's going to give you a more thorough list. I just kind of stuck this in there to kind of give some examples. So let's talk about the past, family, and our social history. You're going to recognize these things too. Okay, your past and social history contains relevant information about the past. What major illnesses have you had? What operations have you had? What hospitalizations have you had? Do you smoke? Do you drink? Past and present medications, dietary status, immunizations. So that is what your past, family, and our social history is for. Do you remember going into the doctor and filling out that piece of paper that says all of those things? Yeah. So that goes into your medical record, and that is your history. And it's important for the doctor to know about those things. So that is our lesson for today. It's going to be a lot of what you're reading today. So I just kind of wanted to go over it a little bit. I want to make sure that you understand how important it is for you to understand those key terms. Understand what a new patient is, understand what an established patient is, understand what a chief complaint is, the reason for the encounter. It doesn't have to be complicated to know what they mean. When they do a review of systems, they're reviewing more than one body system, right? So if you come in for a common cold, that's just one. But if you come in for a common cold and you, I can't think of something now, and you have severe stomach pain, it's two different systems, right? So they're going to review systems. That sound good? That sound clear? Any questions? Yes. Anything you want to talk about?
No, ma'am.
Anybody have
questions?
Huh? What'd you say, Lariana?
Oh, I said, no, ma'am, I don't have any questions.
Okay. Well, yeah, let's just chat for a minute then. Tell me, how do you feel like things are going? Are things clear? Is there anything that I need to improve on? Is there anything that I can do more?
I think everything's been great.
I do have a question. Crossword puzzle. How do we supposed to submit that if it don't show up?
I dropped the grade.
Oh, okay.
I can't make you do something that you can't see. And then I was able to send pictures to some students, but that wouldn't go through either. I have had some trouble. I don't know. It's some trouble. Right. I'm so sorry that happened. I could pull it up on my side perfectly. So I didn't know it was scrambled when I showed it to you though. So I pulled it off of a website. I made it on a website and downloaded it onto my computer. And for some reason, I guess it scrambled it. I don't know.
Well, it worked on my desktop, but on my iPad, it was scrambled all over. So what I did was I downloaded Word onto the iPad and it opened up like that.
Oh, okay. Well, I wasn't expecting everybody to do that. So when something like that happens and it's completely not your fault, the ones that turn it in, I'm gonna grade it, and the ones that can't because they're unable to, I'm just drop the grade. Y'all can't help that. Oh, the one thing I do want to talk about is these discussion forum questions are a necessity. We have to do those. Have to be done.
How many replies do you have to do?
I'm just doing one. I'm trying to make them simplified for right now, and as we go on and we get more experience with them, then then we'll require a little bit more. But I kind of like, let's just take it slow. I do want to tell y'all we have 5 more ladies joining us Thursday.
Wow.
Yeah.
So we're growing.
We're gonna grow big. I have to tell y'all, I get so nervous before I get on here and excited to see y'all. I was bouncing. I was like, yay! But anyway, so I would like to do another Zoom at 10 on Thursday. Who would be up for that?
I'm fine. That's fine. I'll be here.
I dropped in. I have to be at work at 7 that morning.
Okay.
So I just drop in. Probably won't stay long.
All right, that sounds good. What I will tell you is that on Thursday, it will be a fun class. We will code E&M together on Thursday. I will come up with some scenarios. I realize that having a lecture class is not always the most exciting, but sometimes it's necessary. I thought it was necessary to talk about the things you were going to be reading about today because it is so in depth in your book. I just wanted to give a quick overview of it. How many of you watched Queen of Guidelines?
I did. I watched it. That was the hour. It was like an hour and something.
Okay. Tell me, when you're reading your information now, do you feel better about what you're reading after
and
watching
what you
Queen
were
of
just
Guidelines?
speaking about? I have it written down from the Queen of Guidelines.
So I told y'all it was long, didn't I? I warned you, it's long. But I also said it will be worth it. How many of you think it was worth it?
It was, because what you're speaking on today was in the video.
Right. So to me, when I know that they're long, and I watch it, y'all, and I'm like,
yes, I was actually dozing off. I had to like pause it.
It's nice to watch her because she reminds me of things that I've forgotten.